Welcome everybody to this very, very special event on becoming a doctor. And this is a different kind of webinar than I usually have. And it's very special to me because it does mark Blue Star's 10th year anniversary. And it was in June 10th exactly, in 2010 that I met Hye-Jin and she signed up to work with me. So this is a very special reunion as well for me. And this is the first webinar where I'm in conversation with alum. So, and over time, COVID sort of delayed me in sort of connecting back with alum in honor of the 10th year anniversary. So that will still be coming. So hopefully there'll be more alum representing different fields and things like that. But these two very special people both happen to be in the medical field. And, you know, in the times we're living in, we know how crucial, how important, how righteous and sacred our medical care workers are, what they're doing. So I thought this would be just a very timely thing to be doing. And also we got a bunch of students who are interested in medical school, who are interested in the medical field, whether to become a doctor or some other role related to it. So let me introduce the panelists and we will get to our discussion. I do want to say in advance that because we're in different areas and there are a little connectivity issues, that there might be a lag between my question and the response. So just bear with us on that, just technical situation there. So first I would like to welcome and a hearty hello to Hye-Jin Yun, who worked with me on her college applications. And we've got so many memories there. And let me just say that Hye-Jin is an MD candidate and she's president of the class of 2022 at Loyola University, Loyola University Chicago's Stritch School of Medicine. Bit of a mouthful. Welcome, Hye-Jin.
Thank you. Thanks for having me, Amy. I know it's been a long time.
It's been a long time, but I do get to follow you, you know, when you're on social media and see you in your adventures. And it's such a great joy. It's such a great pleasure. And one of the things I did want to say about the work that we do is we get to meet such wonderful people and stay in touch with them and follow them. So the joys of being an educator. And I would like to welcome Roger Fecher, who is Chief Resident Physician at Albert Einstein College of Medicine and at the Montefiore Medical Center in the Bronx, New York. And Roger and I worked together when I was an academic in Ohio, and he started out as a student of mine, taking a bunch of classes. Then he was a fellow for the honors program. And we stayed in touch. And when it came time for Roger to apply for his MD, PhD programs, he asked me if I would help him. And I was just getting started on admissions back in the day. And I said, sure, why not? Because, you know, it's always good to get that experience and to help with students. So welcome, Roger.
Thank you so much. Sorry, my pager just went off.
Are you okay? Do you need us to?
No, yeah.
Well,
I should. Okay, sorry. Yeah, sorry.
It's the life of a doctor.
In real time.
So yeah, I did my MD PhD and then started chief residency here in the Bronx. So sorry, I missed a little bit of what you were saying, but glad to be here. Hopefully I can help answer some questions that people have about what it means to be a physician and the process of getting to this stage.
Well, I know you are very busy and we will get to some details of what you're doing in your field right now in the midst of COVID. So just thank you so very much for joining us, Roger. I really, really appreciate it. You know, so I knew Roger as a college student. I was associate director of the honors program. We did a bunch of different sort of extracurricular things together in terms of different programs that we were putting on, but he was also a student of mine. But I cannot remember what your major was. So I thought I'd start out by asking each of you, and Roger, what was your major in college?
Yeah, so part of it also was probably that most of how we interacted was not through my major. It was really through the Honors Institute and the philosophy. But my actual major was biological sciences. That's all I came away from in terms of an actual degree, but also that was partly because at the time there wasn't a neuroscience major when I was an undergrad. So I did take graduate level neuroscience classes as well as the medical school neuroscience classes. And then also took a number of philosophy and religion courses, and then actually took some film study courses as well. So I was kind of all over the place in terms of what I actually studied. But yeah, my actual degree is biological sciences.
And so, Roger, too, can you tell the audience where you got your undergrad degree?
Yeah, so I did my undergrad at Wright State. So I'm from Dayton, Ohio. Wright State is in Dayton. Always knew I wanted to go to med school, and so my undergrad was paid for. That was like one of the reasons that I went to Wright State, because I already knew that I wanted to go to med school, and so in order to keep costs down a little bit, I went somewhere that I could get a full ride. So yeah, so didn't pay anything for my undergraduate, which definitely helps in the long run. I don't know how much people are aware of it, but the average med school debt now is around $200,000. So definitely not an inconsiderable amount of money. So something to think about.
It is something to think about. And I specifically wanted to talk to you about where you went as an undergrad to let our audience know that you don't have to go to an Ivy League college to get into medical school and to have an amazing career, which you're going to talk about in a little bit, right?
Yeah. I mean, and I think, you know, I can comment to that a little bit too. I'm currently interviewing for neuropathology fellowship programs, and I've interviewed at Northwestern and was offered a position there. I've also have interviews set up to interview at MD Anderson, Columbia, and Johns Hopkins. So, I mean, you're right that, you know, no matter where you come from, you can later continue to train at these prestigious institutions. So I think that's kind of the point that you wanted to make.
Yes. And also too, you know, when we have a lot of students who come, families who come, they want their child to get into a top school, a top 10, top 20, top 50. And often and then they say, my child wants to be a doctor. And I say, well, you know, there's the route where you can target schools that have high acceptance rates for medical school, or you can go to a safety school where you're at the top of your class that maybe isn't a brand name school. Very few people take me up on these other strategies. Do either of you want to speak to that?
Yeah, I think I can address that well. So it wasn't really something that I thought about going into it. Like I said, it was really a financial decision. But when I was applying to medical school, the dean of our college wrote me a very personal letter because she knew me very well, because I was considered like one of the excelling students within their college. And then in terms of research opportunities, it was not that challenging for me to get into research. So I had been working a fast food job prior to then, and was able to start working in a neuroscience research lab, and ended up getting the Barry M. Goldwater Scholarship. That's what Amy and I kind of worked on, was my application for the Goldwater Scholarship, which is a really prestigious undergrad research scholarship. And the thing was, like, when I applied for that research scholarship, you can only have, I forget what the number is, but there's only like 3 or 4 candidates that are allowed to be sent in from each undergraduate institution. So obviously, if you're at a Harvard or a Johns Hopkins, it's much more competitive to send in your application from the from the get-go, whereas it wasn't that hard for me. I mean, I think we actually had a high number in my year, and I think there were 3 or 4 applicants that applied that year. So, you know, it wasn't nearly as difficult to get the university to send my application onto the national level.
Exactly. So that's another piece, and maybe I can do another webinar on national fellowships. I was a national fellowships coordinator at Wright State at the time. And so, you know, these national fellowships, from the Fulbright to the Goldwater, you can apply to them from any college in the United States. And if you're at a less competitive school and you're a competitive student, you have a higher chance. So Hye-Jin, why don't you tell us where you went to college and what you majored in, and whether you knew you wanted to go to medical school, you know, when you knew that?
Sure. So I went to Barnard College at Columbia University in New York City, and I majored in neuroscience and behavior. So I guess 10 years later, I guess neuroscience was a major now. So, and I always knew that I was passionate about health, and I thought I wanted to go to the doctor because obviously coming from an Asian family background, there's a lot of expectation you either going to engineering or I guess law school or med school, and I thought med school was probably more of a fit. But I took more of a roundabout way of getting there. I knew that I was passionate about health, but I also had other, and so I did a lot of performing arts growing up. So for me, it was really important for me to incorporate that kind of creativity into just anything that I did in life. So I pursued broadcast journalism for a little bit. So throughout college, I live in New York City. So a lot of the broadcasting centers are kind of, I guess, centered around New York City. So I interned with the chief medical correspondent at CBS Evening News my senior year. And I love the way you can tell a story and have like 6.3 million people who look at the stories and be really affected by that. But what can you do about it if you're just a reporter? I think you just report stories, but you don't really have the license to actually do something about it when it comes to health stories. So I was really compelled by that humanitarian perspective and worked with UNICEF USA for 2.5 years after I graduated, and worked in the United Nations space, and now have worked my way to medical school. And I think, to Amy's point, it doesn't matter, like there's only like 7 Ivy Leagues in the country, and I was part of the Ivy League institution for 4 years, but I gotta tell you, after having gone through that institution, it's so much more important to find a college that is the right fit for you. Like you have to be in an institution where you can thrive, because I have plenty of people who, a lot of smart friends, like Columbia people are smart, but like not everybody's gonna thrive out of that competitiveness or that really hardcore pre-med classes where you're just a number. So I think just really finding the institution that's gonna help you to blossom and help you to become the physician or pre-med that you want to be, I think is more important, because you have to write I know you guys are all might be writing your college essays now, but it doesn't end. You gotta write your medical school personal statement. I'll be writing my residency personal statement like less than a year. So it never ends. So just figure out what your story is, and don't try to be like anybody else. Just be yourself, because everybody else is taken. So that's all I can say for now.
Thank you. That's so helpful. And, you know, this is very much at the heart of our practice of trying to get to know students and then figure out, okay, what's the best path for this person? Not always thinking about the brands, you know, that sort of thinking from that perspective. So you're in your 3rd year of med school at this point?
Yes. Just moved. I just finished my neurology clerkship. So super exciting.
Congratulations on that. That's great.
Thank you.
Do you want to give us a sense of, you know, what can people expect when they apply to med school?
Sure. So I applied to I'm not even kidding. I think I applied 47 medical schools, because we are at an age where I think med school admission rate is super, super low. I think for Loyola it was 2%, I think, when I applied. So it is about a 18-month process. So it's a 1.5-year long process, I would say. So you would have to take your MCAT, which is your, I guess, medical school entrance exam. And they just changed it my year. So like it's now 8 hours long instead of it used to be like, I think 3 hours long. So a lot of people spend a good chunk of time studying for that exam. And you want to always take that exam, I think, about a year out from when you want to apply. And then once you have your score, then you want to start thinking about your personal statement, because I think the key to medical school admission process nowadays is to submit your application really early. So I know for college, you submit, I think, like December 31st, but if the deadline for med school is December 31st, you apply the moment that you open application. So for me, that was June 1st, I guess in 2017 or 2018. So once you get your applications in, you have your, you got to ask for letters of recommendation. So I had to submit 5 letters of recommendation when I was applying at the time. And for every, I guess, application that you submit, there's also like a supplemental essay. So you have your main personal statement, kind of like I think how college essays are. And then for every med school that you apply to, there's also the supplemental essays that's specific to that school. So you also want to do a good research so that you're not just copying and pasting, because med school admissions kids could tell when people are copying and pasting. But they're very similar, so you could tweak it, but always make it personalized. So it's not just copy and pasting. So that will take you, yeah, go ahead.
We train students in the why essay, you know, for undergraduate admissions, and it's a similar thing. It's like you just change the variables, but the basic gist or strategy, yes. So take what Amy's teaching you now, because it applies to the rest of your life. Like it's not just college essays. Yes. And then you have interviews if you're lucky. I know in college, they kind of offer interviews. At least I remember when I was applying to college, like many moons ago, I had to I got an interview for every college that you apply to. But in med school, they're very selective on who they interview. So when you get to the interviews, you kind of made it to the first pass. And then after that, if you excel in interviews, then you can hopefully get an acceptance. So that's kind of how the process is. It was like literally 18 months, I think, when I applied. And so, Roger, I believe you were on admissions committees at University of Cincinnati, and perhaps you are now as well. So maybe you could talk about it from that perspective. Also, you are an MD PhD, which is something different. So why don't you just talk about what, just from an admissions committee perspective, what you guys find impressive, and then just what the difference is in the MD PhD application.
Yeah, so so I was on the MD PhD admissions committee for a couple of years at the University of Cincinnati, and then I'm also so even starting as a first-year resident here, I was actually interviewing residency candidates, and then as a chief, I have a little bit bigger role in helping decide how we make our rank lists. And so I think the things that really stood out for us, the students, so there's always the grades, and that's the thing that people are always really concerned about. The grades are usually like a barrier to entry. So there are generally cutoffs that different institutions have, and if you don't meet that threshold, they don't look at your application. And it's the reason that they do that is because they get so many applications now that they can't look at all the applications. They don't have enough people or enough time to actually go through all of the applications. So when you hear about these ideas of cutoffs, it's true that places are using some cutoffs. So unfortunately, if your MCAT score is too low, nobody's even going to be looking at your application. So you might put together a very good application otherwise, but if your scores aren't high enough, it doesn't matter because you're not going to be looked at. So that's an unfortunate thing, because honestly, the scores that you get are not really indicative of how you perform as a physician. They're indicative of how you perform on future tests. But the issue is that you will have to continue taking those future tests. So MCATs were always only good at predicting how you do on your step exams. Step exams were only good at predicting how you do on your board exams. And while those aren't actually the practice of medicine, they are required steps along the way. So it is important that you study for and do well on the MCAT. But then once you get past that barrier, it doesn't matter if you have, unfortunately, I don't know what the scores look like, because I know that they've changed the MCATs a couple times. So I can't even give you good number guidelines at this point about where you need to be. So hopefully you can talk to someone that can give you a better idea of like where your numbers should be. If you meet those thresholds though, that's when we're, again, like Hye-Jin was saying, we're looking at who you are, at your personal statement and your letters of recommendation that really speak to your character, your interest, your passion. So, I mean, it's super important in your personal statement to demonstrate, especially for MD, PhD, why you're passionate about research, why you see yourself in research moving forward. The MD, PhD curriculum is definitely geared more toward the research side of things. So we're assuming that people who are applying are interested in becoming a physician. There's very little question about that idea. What gets to be very challenging is the research motivations that individuals have. And so we really want to know that you're passionate about the research, that you took an active role in designing the projects that you were working on, that you were formulating the research questions, and that you actually know what you're getting yourself into. Because if you haven't taken that active role and you don't have that background, then those are the type of people that get to their PhD and then drop out, because it turns out that they're not that enthusiastic about research. And all of this is a lot of work. You're going to spend a lot of time. You're going to have many sleepless nights doing all of this. So if you're not passionate and motivated, then you just won't do it. So that's really what we want to see, that you're passionate, that you're enthusiastic, and that you've had some experience to demonstrate that you can do this and that you want to do this. So, I mean, that's one of the things that I think we'll talk a little bit later about, the things that you need to be doing to improve your application. And I think exposure to the fields that you're interested in is something that's incredibly important, because it's easy to say that I want to be a doctor, but what does that actually mean? Do you actually know what a physician does on a daily basis? Because you probably don't. Unless you're working with someone who's a physician, you have this idealized perception of what it means to be a physician, but it's hard for people outside of the field to actually see what it means. And I think that's actually been highlighted with the coronavirus, because people don't understand. I mean, we went through a lot here in the Bronx, but most people outside of medicine didn't see any of that, because you're not on the floors, because you're not seeing the anesthesiologist intubating all of the patients. So, you know, I think that's a big part of it, is knowing what you're getting into and knowing that you're committed to it, that you're passionate about it, that you're excited to go out.
Yeah, and honestly, this is everything that we say about undergraduate admissions as well. You know, you can't just say, I want to be a business person. Well, what have you done? You know, so we're actually, you know, the undergraduate admissions is almost like training ground for this at this point, to be successful. So this is, it really aligns with a lot of what we're talking about as well. Hye-Jin, what is the most exciting thing you're doing right now?
I think you should ask Dr. Fecher that first, because he's like done so much more exciting with the COVID cases. I think for now, I just went over the hump of the most dreadful part of med school, which is just 2 years of pre-clinicals where you're just studying nonstop, like 24/7 really. And I just took my first medical, I guess it's called step 1, which is your first board licensing exam that you take. And now I'm out in the floor. So the most important, I think most exciting thing is now you're finally part of the healthcare team and you're doing what you came to med school for. You, because I think the first 2 years really feels like college all over again, which is great because you get to hang out with people. But it's just a lot more studying. It's really drinking water out of a fire hydrant. That is very, very true. But I think now that you are the next generation of the trainees, so you do the best you can to be helpful. Because to be very honest, as a medical student, you still don't know very much about how medicine works until you kind of go through the 2 years. And I still don't think you will know much by the time you come out of med school, because I think once you start internship, that's I think when you get into the grind of things and really start doing a lot of more the administrative aspect of medicine. Because I think as medicine, you're very much protected from doing a lot of the ordering and the things, a lot of paperwork that I think we're sheltered from. And I think right now I'm just trying to enjoy learning for the sake of learning, because I think now you're just putting all the disease and pathology to a face now, because now you're facing that in a patient. And I think that's something that's so beautiful about being able to take somebody's history, because as medical students, you're so scared you're gonna miss something, so you take very intense like history. Because as you guys get to be Dr. Fecher's level, like you don't have, I don't think you get time to take out much history, because you're just seeing patient after patient and managing a team, and he's also the chief. So I can only imagine how busy he is. But I think as a medical student, you do the best you can by at least listening to the stories and making sure you're not missing pieces that maybe the residents or the attending physicians or your interns might be too busy for. So,
well, congrats on getting through your step 1.
Thank you. It's the hardest thing I've ever done. so far, because this step 2. So
the next leg of the journey, yeah. So, and Dr. Fecher, why don't you just tell us a little bit, like, what you were doing before COVID, and then how that shifted, and what you're working on.
Right. Okay. So, so I'm in pathology. So I think as much as I say that people don't necessarily know what physicians do, people really don't know what pathologists do. Even a lot of people working in the hospital have no idea what pathologists do. It's one of the strange things, because we're the only department that everybody orders things from, but very few of us actually see us. Very few of them come to know what we're actually doing. It's this, pathology is like a black box where I think people on the outside, you put in pieces of tissue and then you get pieces of information back out. I mean, I think that's how most people see it. So, you know, which is great for us in some regards and not so great in other regards. So, I mean, so pathology is on the very diagnostic end of the spectrum. So there's this spectrum within medicine where you have from the taking the patient. So the first people to see the patient. So you've got family physicians who, I'm sure everyone has been to a family physician who is taking your temperature. If you have a problem with your knee, they're doing the physical maneuvers to try to figure out what's going on with your knee. You won't see us until you get to a much later stage. So, you know, we do autopsies in order to determine cause of death in people. We run chemistry. So any of the blood or other fluids that are collected in the hospital are sent to our department to analyze, and then we send results back. If someone has cancer, the tumor itself is sent to us. We dissect that tumor. We create slides. This is not a patient slide. This is a teaching slide. But like, this is a slide. So this is a piece of, I don't know. There's a pink piece of tissue that you can kind of see there. This is a piece of brain tissue. So, and then we create diagnoses, and the importance of that is knowing how to then treat the patient. So diagnoses are necessary to know what your prognosis is, to know what kind of treatment plan is an option. For instance, if we're seeing that you have widely metastatic disease, then it's not something that we're really able to cure. And so we do palliative treatments to help, you know, in the end of your life. Whereas most of the time we can either surgically resect or treat with radiation or chemotherapy. So we're one step away from like what most people think of as physicians, because I don't see there's very few areas in pathology where I see patients. So in the blood bank, when people are getting plasmapheresis treatments, we see those patients. And then we see patients on cytology, where we might do a fine needle aspiration. So if you've got like a mass lesion in your neck, we can stick a needle into that lesion, pull out cells, and then do a diagnosis based on those cells. So there are times that we see patients, but most of the time we're not seeing patients. So we're really on the diagnostic side of the equation. So during COVID, I spent time, so as chief, one of the things that I wanted to do was try to keep individuals' exposure as low as possible. So one of the difficulties in the Bronx was that New York City in general was one of the hardest hit areas, at least early on. Things seem to be changing at this point, but we were hit quite hard from the get-go. The Bronx actually was hit the hardest of the boroughs. And so we saw a lot of COVID patients. At one point in our hospital system, we had 1,900 COVID patients. At the Moses campus alone, which is where I'm sitting right now, we discharged 5,700 patients over a 2-month period. I mean, just massive amounts of people coming into the hospital and going. So, and so from a chief resident perspective, again, we're not seeing patients, but we're collecting all the specimens from those patients. So there's still a high risk of potential infection with when you're handling COVID specimens, especially the individuals who are performing the molecular analyses to determine if you have COVID. Because at the beginning, you know, we were seeing 60 to 70% of those specimens were positive for COVID. So almost everything that's sitting on the bench in front of you has COVID in it. And so we tried to put people at like more back of the house positions where they were developing assays that were necessary to respond to the crisis, but not having to do that kind of work. And so I myself went on the molecular service. So I helped initiate the testing platforms that we use. So we initially had instituted a hologic platform and a Cepheid platform to test for the virus. So I helped generate those. I created cohorts of our patients to determine predictors of how people would do. So we were looking at individuals who were hospitalized but not intubated versus patients who were either intubated or who passed away with COVID, and trying to do predictive analyses to try to figure out what factors were associated with those individuals who got very sick. And a lot of what we saw was the same things that people have heard reported. It was old people, people with multiple comorbidities. Yeah, and so that's one of the things that I did. But then I also worked in microbiology, actually running the testing. So I was one of the people pipetting this stuff, those patient specimens into the Cepheid cartridges to do the actual testing. So yeah, it's a little nerve-wracking, but it's obviously something that was vitally important. So we triaged all the specimens. So we set up a triage for how to triage these specimens. We created a new unit within our chemistry department to deal with those specimens, so that not everybody who was working in chemistry would have to be exposed to those patient specimens, you know, to try to keep down the number of people that could potentially be infected. And then we noted that there was some difficulty in detecting the RNA within some patients. So I also helped design and perform stool testing. So we found that there are individuals who are never positive for the virus, even though they have a very compelling clinical presentation. And the thought was that it's because they're not shedding in the upper respiratory tract. So again, the swabs that we do either go in your mouth so an oral pharyngeal swab or down your nose, a nasopharyngeal swab. And so you're only really testing the upper respiratory tract. And there was literature out there to suggest that coronavirus was shed in the upper respiratory tract for about 2 or 3 weeks post-symptom onset, whereas stool secretion could be maintained for at least 4 weeks, but potentially longer. And we found that it actually seems to be considerably longer than that. Unfortunately, not everybody sheds the virus in their stool. So it's not a great first line test because, you know, the numbers look like between 1/3 and 2/3 of patients actually have stool shedding. So we can't use it as a frontline test, but it was a great confirmatory test for patients who weren't testing positive in the first place. And so we instituted that stool testing, and we were able to confirm that a couple of the patients on the wards that were clearly from a clinical perspective infected, but had never had a positive PCR, they were infected. And the great thing about that is that because of that, they were able to get on the protocols to actually get some kind of experimental treatments for COVID. So yeah, it really has an impact for patient care because those people could not be treated prior to that because they cannot be considered COVID patients until we actually have a positive PCR. And so what we did was design this test and demonstrate these people are actually positive. And we've had autopsies where that's the case as well, where people were never able to be confirmed positive. And then we were able to perform stool analyses and confirm that they actually were infected with the virus.
So by designing this new test, you were able to get more patients care.
Correct. Yeah. I mean, able to utilize treatment options that otherwise, the thing is that all of our treatment options for COVID at this point are experimental treatment options. But other than the experimental treatment options, we were only getting, they were getting fluids and supportive measures. So they couldn't get anything that we thought might even be curative. So by confirming that they're positive, they can get on these experimental protocols to actually get treatment options. So
this is sort of something related, but not scientific here. You know, what I'm hearing in your narrative is that, you know, someone to be an MD, PhD, you need like skills in strategic thinking, maybe in design thinking. It sounds to me like there are a lot of soft skills that are also needed in your work. And I'm wondering if you could address that a little bit, and then like Hye-Jin to address that as well, because I think that's also it's something that tends to be overlooked as important for the role.
Yeah. Yeah, like Hye-Jin was saying earlier, like the creativity is something that you can definitely utilize. So this like mix of creativity and curiosity. So we think something's going on. How can we prove that that is the case? And then how can we design things to either demonstrate that or to get some kind of new demonstration of like a new test or a new assay or a new treatment option. So I think definitely, being curious about the things, being passionate about those things, looking into it, being excited about going home at the end of a long day to read some of the literature, to learn more about it, and then being creative, thinking of ways that you can implement the things that you're reading into these new models is super important, but definitely something that we don't have like an assay to determine how good you are at these skills.
What are your thoughts, Hye-Jin?
Yeah, to follow Dr. Fecher's creativity, I think one of the buzzwords in admissions actually at our college is cultural competency, because you will see so much diversity in the patients that you serve. So it is really important to be well versed in, I think, just diversity in terms of your patients. So that could be ethnicity wise, they could be socioeconomic because all, at least in Maywood, where my medical campus is located, is very much divided in terms of who gets care, and we have a lot of different patients who cannot afford care and they still come, and how do we kind of educate the people who can afford care versus who are more in the affluent community. So I think it's really important to have that kind of compassion towards other people, because I think as a physician, we are probably champions of humanitarians in a sense, because we study the human body. We probably don't know, I guess we are the few people that really know human bodies as much as we can, given all the literature and all the studies that are out there. So it's really important to be able to kind of sit in somebody else's shoes and be able to understand where they're coming from. Because at the end of the day, I think at least when I was a high school student, I thought like physicians always kind of like told everybody what to do, but that's definitely not the case. You have to give patients the power to make decisions for themselves. We can empower the patients to make healthy lifestyle choices, but at the end of the day, it's the patients who make their ultimate decisions. So we have to be able to empathize and understand what cultural backgrounds they come from, what socioeconomic statuses they're facing. Because I think it's not just enough to be a smart physician, because at the end of the day, we are people persons. Like I think whether you're a pathologist and kind of to help with the diagnosis, or whether you're, I guess, a primary care physician, like facing, I guess, their first screening of COVID tests or whatnot, like it's just so important to be able to work as a team and be able to not just empathize with the patients, but also empathize with your nursing staff, your social workers, because medicine is a team sport. It's not just doctors anymore. It's really the nursing department, the social work, and it's so important to be able to work with everybody.
We have this very important sheet. It's actually a chapter in a college playing workbook that I wrote. It's called the 7 C's, the 7 core attributes of admissions distinction. And curiosity is on there, collaboration is on there, commitment is on there, and cultural intelligence is on there as well. I have them right up here, actually. So that's so everybody who comes to Blue Stars learns about, well, everyone who works with us learns to be good at cultural intelligence, and everyone who comes in contact with Blue Stars knows that's really important. So, well, I guess I just want to ask one more question, because we're sort of coming up on time. I do want to invite participants to beam me some questions. If you have some questions for our panelists, we can stay on for 5 or 10 more minutes. So, Hye-Jin, I'm just wondering some final thoughts or some wisdom. We love our wisdom here at Blue Stars that you would like to share with
Sure. I think going back to, I think what Dr. Fecher said, and Amy, what you said about like just like dedication and commitment. I think this field requires so much more sacrifice than I ever imagined as a high school student, as a college student. I mean, Dr. Fecher can probably speak more about this. You probably work through your holidays. You probably come at ungodly hours. I know for surgery rotation, which is coming up for me, I'm a morning person, but like 4 a.m. every day. Like I can do 5 a.m. but 4 a.m. every day. That's, it just has a lot more commitment, and you are always going to feel like sometimes you're not enough, because there's always so much more to learn. So I think Winston Churchill said, success is not final, failure is not fatal, is the courage to continue that counts. And I think medicine is one that requires so much courage. I mean, we see so many people in the front lines working, and if that's not courage, I don't know what is. And I think just that willingness to be resilient and keep going, and not losing yourself or your curiosity along the way, because I think it's just so important. Medicine is a lot, and sacrifice, I don't think does justice to what we have to go through. But I think if you are so passionate about something, and more so if you're passionate to help other people, because this is one of the few fields I find that you can really have a direct impact on people's lives. Like people will be coming to you when they're at the end of the lines, or they're gonna disclose information to you that they won't disclose to, I don't know, a lawyer per se, or a business person. So it is such an honor to be able to be part of their care and their lives. So we have to work really hard to make sure we are capable of making sure we take good care of them.
That's super helpful. Thank you so much. Roger, some
Sure.
final thoughts and wisdom?
Yeah, so I guess I'll echo something that Hye-Jin was saying about I think teamwork is something that is becoming more and more necessary in medicine. I think people think of a physician as being like this lone ranger that goes out and solves problems, curing people. The thing is that that's definitely not how it works in modern medical practice. You work with care teams. You work with people, you work with physicians from other departments, you work with nurses, you work with techs. You're going to be working with a bunch of people of all different types of backgrounds, doing many different types of things. Some of the times you won't know exactly what they're doing. And so, it's really important that you understand that you're working within a system and that you need to learn how to collaborate with other people. And as a part of that, you really need to learn how to communicate better with people. It's still tough, and we still have difficulties with poor communication within medicine, and it leads to issues with patient care. And that communication is not just verbal communication, it's also written communication. As a pathologist, a lot of times the only information I have about the patient is what's written in the patient's notes. And so when the intern that saw the patient wrote a poor note, I don't have a good picture of what the patient looks like. Or if details are left out, I can't just ask the patient because they're not sitting there with me. And so being able to communicate effectively with other people is incredibly important. And it's definitely a skill that translates well into your application process too, because you need to be able to communicate who you are and why you're interested in the things that you're interested in. So
this is so much a part of our work at Blue Stars as well. In fact, students have to sign an agreement about, answering emails and, we tell them that this is your training in collaboration. And then of course, communicating clearly is over the years with high school students, we work on that. So very helpful. Thank you very much. We do have a question. And so the question is, do you have any undergraduate major advice? Can one major in a humanities subject and still be pre-med if they have taken all of the prerequisites for medical school? Roger, do you want to take a first step?
Yeah, so definitely. In fact, if you look at it's been a couple of years since I've actually looked at the literature. I'm sure there's additional literature out there. Actually, the percentage of like biological science or chemistry or like these more traditionally hardcore science backgrounds, the percentage of people coming from those that get accepted to med school is generally lower than it is in the humanities. So definitely on a percentage basis, it seems like it's somewhat an asset to be from those humanities backgrounds. And the thing is, like, if you actually get to the interview stage, so again, you need those pre-med background so that you can take the MCAT, right? You need to be able to perform well on the necessary testing. But if you can get to that point and you can get an interview, then having a background in the humanities gives you a lot of things to talk about that are going to be different, that are going to let you stand out compared to the other applicants. So I think if anything, it's probably an asset for the most part to have a humanities background. And that's coming from someone who has a hardcore science background, so.
Agree. There's actually a program in Mount Sinai School of Medicine, where they actually have a special program for people who major in humanities. So you apply, I believe, your sophomore year, and you have a guaranteed acceptance to a med school if you do well in your classes. And I don't think you even have to take your MCAT for that. So I think humanities is an important part of medicine. That's why we call it the art of medicine, right? Because I think art is a big part of humanities. So I think college is one time where you could study anything
just for the sake of learning. So really take that advantage. As long as you take your science classes, I think being a pre-med and being a science major often overlaps, so it might be easier. But I think to Dr. Fecher's point that it's such an asset when you get to the interview stage and and you're that one person who's not a science major, right? So.
Cool. I'm just writing the program at the Mount Sinai in chat here for sophomores, right? Just so, wow, that's very helpful information. Good. Well, it doesn't look like we have any other questions. And this has been so valuable. I feel like we can sort of wind down at this point and let you guys get back to your busy lives. And I just want to thank you so very much for participating and sharing all of this information and wisdom. It's so very helpful. So I'm going to wish everybody a great, and we're getting some notes that this was very informative. So the audience agrees. And I just want to wish everyone a great, healthy, safe, socially distanced holiday weekend. And thank you guys again so much. And let's stay in touch and hope to talk to you soon. Take care.
Absolutely.